I request Dr. Ramamurthy sir to please come forward with his presentation. Anand.
At the outset, I would like to thank the organizing committee of this wonderful meeting and this session to chairpersons to have given me this chance. Let me, in 3 minutes, 5 topics, let's try to finish it. Morganglian cataract like this, you'd find that one of the safety measures that I employ sometimes is IOL scaffold. You know that these cataracts can often be associated with a tremulous capsular bag. There is a tendency for the capsule to trampoline forwards. So in these cases, I'm sorry about that. That's the liquefied cortical material which is flowing out, and the capsulorhexis is not really a challenge in these situations because I think let's. It was running fine. If you want, we can skip this video and. Huh? Okay. Yeah. So as you can see here, that's the lens material which flowed out, and it's a nucleus which is hard as a nut but quite small, but obviously this will spin around and there's always a tendency for the capsular bag to move forward. So what I do is before doing the phacoemulsification, I go ahead and implant the lens, as in this case a single piece hydrophobic acrylic lens. Obviously this can be quite challenging for the corneal endothelium. But as you can see, it's a brittle cataract, and with a significant amount of dispersive viscoelastic, we go ahead and remove the lens, and then that intraocular lens acting as a safety measure as far as this case is concerned. Next. It's not working here. And hydroimplantation, many of you might be already doing it. It's a good idea to have an irrigation cannula all the way inside, and as you can see here, that acts as guides the lens into the capsular bag directly. It's a 2.4 or a 2.8 millimeter incision, depending upon the kind of intraocular lens that you are implanting. It's a toric implant. I have the Varion overlay on, and you would see it right in the end. And you are able to position this. Initially, I kept the IOP 90 just to bloat up the capsular bag, but then I bring it down to my normal 30, and that's the intraocular lens which has been placed. There's no, especially with toric intraocular lenses, it's an advantage because there is no viscoelastic that needs to be evacuated. That shows the positioning of the lens. Next. This is something that I do routinely. After removal of the nucleus, it's just a stream of fluid, BSS, that is polished onto the posterior capsule. Whatever small tags, fibers that are there are completely taken off. This gives you a great impression of clarity right on the operating table, and also on post-operative day 1. It's nice to see these eyes on the slit lamp with a crystal clear posterior capsule. Of course, if it's a fibrotic patch or something, that's not going to come away. But any fibers or any small pigments on the posterior capsule, it's easily washed away. Next. And can you just switch on to? There are several patients who have had a monofocal implant earlier and now want independent sunglasses. And especially if the patient has received a multifocal implant in the second eye and now wants the first eye something to be done, which was operated years back. This is a diffractive trifocal lens which is available from an Indian manufacturer, no financial interest. And I don't use it very often, but this is a choice. And you can implant it. It's a hydrophilic acrylic lens. It comes with a 1.75 and a 3.5 diopter add. And this seems to take care of the intermediate and visual needs of the patients. Next. And finally, as far as the toricity is concerned, very often I am asked what is the power beyond which you suggest a toric lens. But then what you must understand is that it's not just the power alone. Axis itself is extremely important. When you are using something like a, can I use this? No, the previous slide. Okay, thanks. When you use something like this, 0.60 against the rule astigmatism, and you find that what the Barrett toric calculator is recommending almost a T5 lens to be implanted, T3 lens to be implanted. It's little more astigmatism than that, a 0.68 astigmatism, just because it's oblique astigmatism, it's a non-toric that's needed. So it's not just the cylinder alone, quantity alone that's determining this, but also the axis of the cylinder is extremely important. So our go-to formula today is not Barrett Universal 2, but Barrett toric calculator. Every patient gets examined in that, and depending upon what the cylinder is suggested, you can go with it. And it is not just in case you don't have an optical biometer, you can go to the ASCRS or the APASCRS websites. Right on the home page, you have this drop-down menu. You can use the same formula, and what I am trying to drive home, you can see that a 0.75 diopters 180 against the rule astigmatism, the lens that is needed is a T3. The same amount of astigmatism, 0.75 at 90, the lens that's recommended is non-toric. So it's not just the dimension of the astigmatism, but the axis also that matters. Thank you so much.
Thank you, sir. See, the IOL scaffold is actually more protective to the endothelium. See, you have these sort of cataracts with milky cortex and all. Even the posterior capsule will be a bit floppy. Yeah. So if you're doing without the scaffold, you have a tendency actually to come more up. With the IOL there, you can safely go more posterior. So for me, with an IOL scaffold there, it is actually more protective rather than more damaging to the endothelium.
And usually I give a dispersive viscoelastic, and then feed in some HPMC, and
obviously we'll be using. Yeah. But the position of your phaco tip, I'm telling,
you're more confident.
Yeah, you're more confident to go more posteriorly, because it's definitely not going to catch the PC through the sides of the small nucleus that is there. This was a bigger one. You have very small nuclei coming in there. Definitely the scaffold will be much better. You know?
Yeah, the thing is, many smaller or moderate nuclei, I push it back into the back. And sometimes I only tilt and get the IOL inside, and the phaco happens in the bag itself. So if it comes on top, as you said, there is much more space actually, rather than what we think. But still in the AC, I do not split so widely, you know, and I don't do the regular kind of complete chopping. I do partial choppings and put in viscoat intermittently, and then do it slightly slowly, so that...
I'll add to that. See, phacoing on top of this IOL is a funny feeling. Like it keeps slipping. So what I do is eat a portion of it, then you hold it. Then you can chop easily. One portion you eat, hold it there, then you chop. It works wonderfully well. Anything?
Sir, regarding your comment on toric lenses, which is the calculator that you always use the toric, the Barrett toric?
Yeah, you know, we were using
and you
the
go
Barrett
according to the recommendation of that itself. You don't make any changes or...
No, what I am trying to say is when the patient walks in with the cataract, first time he is made to sit on the optical biometer, we use the Barrett toric calculator. Earlier we were using universal 2, then the patient will say just a 0.7 diopter, counsel the patient for multifocal, etc. Then you find that the patient needs a toric lens, and then the entire counseling changes. Now with this, if we find T2, we ignore, but if it is T3 or anything more, especially if it's a multifocal lens, the entire counseling is for a toric multifocal or a toric monofocal, and if it's less than that, it's a we find it works very well.
Suppose you've already had a multifocal in one eye. Second eye, you find that the astigmatism is slightly more. Do you go in for a toric multifocal, or till what level would you go in for a normal multifocal?
No, as I said, I don't go by level at all. I mean, not the number of the cylinder, but what does the calculator tell me? If it's sometimes highly demanding patients, cost is not a criteria, trifocal lens you are implanting, I go ahead and implant a toric trifocal even for a T2. T3 onwards, whether it's a monofocal or a trifocal, we tell the patients you'll be missing something if you don't go for a toric. And that seems to, and second eye, there are so many cases, we're not so concerned about toricity earlier. And some patients who have been done by us itself 3-5 years later, now come back with us for the second eye. We tell them this is a better lens and many of them accept it.
Yeah, I think toric if it is multifocal, if there is some, even the T2 or the smallest one is showing, I'll better take a toric multifocal than this one, because otherwise, mostly they are very happy with the other eye. Then a slight thing also, they will say this is always a little smaller. So I don't avoid the toric lenses.
I think residual toricity is one of the most important causes for an unhappy multifocal patient.
Absolutely.
Absolutely.